are, so we hope we're live streaming now. Good evening, ACPinners and physio fans. Welcome to ACPin Southwest's first event of the year. If things go well, it won't be the last, so do click the subscribe button and a little notification bell too, so make sure you don't miss a thing. A little word about housekeeping. This is our first attempt at a live broadcast like this, so if you do lose us part way, please don't leave. We will have a good go at reconnecting if that does happen. So do allow us a good couple of minutes if you get disconnected. I'd like to thank Dan Baxter and Erin Cowley of Hydra Hub here in Newton Abbot at Seal Haying. Hydra Hub is one of the region's only hydrotherapy pool open to members of the public and is fully accessible. The heated pool is open to people of all ages and abilities and allows everyone to enjoy the benefits of exercise in warm water, and it's opening on the 25th of July. So we're nearly there, and things should be a little bit back to normal, which is great. So without too much further ado, Associate Director of Nursing and Professional Practice from Morsea Healthcare of the Older Person and Stroke, Torbay and South Devon NHS Trust based at Newton Abbot, the community hospital in sleepy old Devon, except it's not sleepy. Rhoda's been at the forefront of many developments in the UK and is a leading authority on her subject tonight. So we're regarding the use of botulinum toxin for the treatment of people with spasticity. So there'll be a chance to ask questions at the end. You can write them in the comments at any point, and we'll try and have a go at answering them as we go along, or at the end. Right, so if things all go well, Rhoda is live. Give everyone a little wave, Rhoda. Good evening.
Leave it here, aren't I? Good evening. Hello. Thank you very much for the opportunity to talk about botulinum toxin injections and treatments. So I've never done a discussion like this before, and normally I much prefer to have conversations with people about stuff rather than stand and deliver. So it's quite hard to be faced with a camera. So I hope it's going to be helpful, and I look forward to some interaction at the end in terms of questions. I'm here with Laura Shenton, who is now the consultant therapist for stroke in Torbay and South Devon, who also runs the Spasticity clinic. So there's two of us here to share ideas for the questions. That'd be great. Okay, I'd like to start with a slide which has a picture of a stone tablet on it. So this stone tablet is actually in the British Library in London, and it appears to be the earliest reference to stroke in the world. So it's from 1600 BC, and it describes the symptoms of stroke. So you can forget what everyone said later about the description of apoplexy and Hippocrates. Stroke was known about much earlier. And this tablet also describes the treatment for stroke. So it largely talks about the need for massage, hot poultices, incantations and bandaging. And there's a direct quote from the tablet where it says, "If when he tries to bend or stretch out he howls with pain and saliva flows from his mouth, then an animal spirit has possessed him. And the treatment for that is more incantations, poultices and massage and bandaging." So stroke rehabilitation has probably moved on a little bit since then. I sometimes wonder what people will look back on in 100, 1,000 years' time and think about what we do now, but I guess we do the best you can at the time. Okay, so I've got a slide of what I think it might be helpful for us to talk about tonight. So I'd like us to talk a little bit about what botulinum toxin is and how it works, a little bit about how it can be used, but also a bit about what it can't do, and a bit about the risks, so that if you are considering injecting or are an injector yourself, or if you're thinking about referring somebody for an injection, you get a rounded picture of all the downsides as well as the upsides. I'd like to talk a bit about how it fits in with an MDT plan and how you would practice in spasticity management. Talk a bit about if you're planning to practice as an injector, and then a little bit about resources. Andy's looking at me, is it okay? So if we go on to the next slide, it talks a bit about what is botulinum toxin. So I've put the abbreviation BONTA, which is how we abbreviate botulinum toxin type A. So botulinum toxins are basically exotoxins that are produced by Clostridium botulinum. And they are actually several different strains of botulinum toxin. So there's botulinum toxin type A and B, and then we've got C, D, E, F, G. So A and B tend to be used therapeutically. And there are 3 types of botulinum toxin A. ABOB botulinum toxin, INCO botulinum toxin, and ONA botulinum toxin. So they're all actually slightly different versions of botulinum toxin type A. So, and you may be familiar with the names they're marketed under: Dysport, Xeomin, and Botox. So they are not all just versions of the same drug. Like if you wanted to have an ibuprofen, you might go and get a generic ibuprofen, or you might go and get a Nurofen or whatever, and it's the same drug, but it's maybe slightly different packaging or slightly different other ingredients within the mode of delivery. Botulinum toxin A, those 3 different types are actually all different versions of the toxin. So they're not comparable with each other. We can't compare doses. We can't compare exactly how they work. So 3 versions of botulinum toxin A, and there's 1 version of botulinum toxin B, Neuroblock, which is also used therapeutically. Okay, so I've got a big picture now of botulinum toxin and how it works. So this picture is of the neuromuscular junction. So that's the little bit that comes down and then sits on the muscle and produces that interface. So the picture on the left shows what happens with normal nerve to muscle transmission. So you have a number of substances required, which then work together to sit on what's called the synaptic vesicle. So that's just a little part of the end of the neuromuscular junction that then releases acetylcholine into the neuromuscular junction. So acetylcholine is an excitatory neurotransmitter. So it acts to excite and to make nerve impulses then get communicated to the muscle, so the muscle then contracts. So in normal activity, we need these substances, these snare proteins, this SNAP25, to be together, to work together for the synaptic vesicle to then release acetylcholine. So what happens with botulinum toxin is that the botulinum toxin cleaves, so breaks apart part of these snare proteins, and then that prevents, there's no interaction with the synaptic vesicle, so then it cannot release the acetylcholine, and therefore there's a reduction in the nerve transmission that takes place. So to summarise on my next slide, which has got a bit more, by blocking acetylcholine, botulinum toxin basically causes what we say is flaccid paralysis. Now, I don't think it makes everybody completely flaccid, we'll come to that, but yes, it causes paralysis. Because acetylcholine is involved at other places other than the neuromuscular junction, it also can affect other things as well. So it can affect gland activity, and you may be aware botulinum toxin is also licensed for hypersalivariasia, which is if a person's producing too much saliva from their parotid glands, a botulinum toxin injection can actually act to dry that up. Equally, it's also got use in hyperhidrosis. So if people have a lot of sweating, perhaps of the palms or of the axilla, botulinum toxins can work to dry that up too. Botulinum toxin also has an impact on the expression of pain pathways. So one of the products of botulinum toxin has a license for chronic migraine and reducing chronic migraine headache. So it's not really clear how the mode of action works for that. And it's not really clear what the mode of action is on the pain pathways. It was simply picked up as there were more trials of botulinum toxin, people who were having botulinum toxin for something else, and those with headache started to report an impact on their headache, so then it got investigated further. So that's how botulinum toxin works. So if we're going to use it for either spasticity treatment or for dystonia, given what we've just talked about with the mode of transmission and the fact it blocks these proteins, we need to get the injection as close to the neuromuscular junction as possible. So it's an intramuscular injection into each individual muscle that requires treatment, and we target the neuromuscular junction as much as possible. So you may be aware that when we're performing botulinum toxin injections for spasticity or dystonia, it's often recommended to use a technique that helps localize to ensure we are in the correct muscle, that we are in a muscle at all, and that we're as close to the neuromuscular junction as possible. So typically injectors will often use either an EMG machine or an ultrasound machine to ensure they're in the correct place to get the response they need. So I'm going to talk a bit now about how it actually works clinically. So I've got a picture of the Icf Framework, which I'm sure you're all very familiar with. We're just going to talk about it in terms of, under the Icf Framework, we tend to talk about body function and structures, activity and participation. So I think what might be helpful is to look at how botulinum toxin influences body structure and function, activity. We'd be hard pressed to find much evidence about participation, but we're going to talk about it that way. So I'm going to put up some box plots. So the first one is from a systematic review. So this was a systematic review looking at the use of botulinum toxin in children. And this first plot is of the impact of botulinum toxin on spasticity in the leg. So I'm going to talk through how the box plot works, so forgive me if you're very familiar with this, but just so that we all are on the same page. So down the left-hand column, there's a list of the individual studies that are included in this systematic review. And the very first column in, which is headlined with an N, tells you how many participants there were in that study. So for example, the first study that's named, Ibrahim, 2007, was a study that looked at plantar flexors with only 15 people in it. Are we okay? Mm-hmm. Right. So 15 people in the botulinum toxin group and 15 people in the control group. And if you read down the plot, it gives you the information about all of those. Now, if we move across the plot, you then start to see a line with indicators of the amount of effect. And if we look at the bottom of the plot, if you're one side of the line, it shows that study shows there is a better outcome with botulinum toxin. And if you're the other side of the line, it shows you that the results show there was a better result with the control group. And what you will see in this diagram is that almost every study shows that there was a better effect in the botulinum toxin group. And if we get right to the bottom where it's subtotal, that diamond shape indicates for each muscle group what the summary, if we summarise all those little studies together. So you'll see that for plantar flexors, for hip adductors, and for hamstrings, those little diamonds are all completely clear of the middle line. So that shows that there really is quite, if we summarise all those studies together, there is statistical significance showing that there was a better effect. So that tells us that botulinum toxin clearly reduces spasticity in the leg in children. If we do the next box plot, so this is now looking at what impact does botulinum toxin have on the range of movement in the ankle in children. So this is an example. Now just to make this harder, the box plot is a bit reversed. So if the results are to the right of the middle line, it's showing that botulinum toxin has a better benefit. It's to the left, it favours the control. And again, you'll see with the summary of the results, it shows that there was a significant improvement in the children that have botulinum toxin in their range of movement. So I guess what we're showing so far is with children, and the evidence is the same with adults. I haven't put them in because we get quite bored going through them. There is clearly an impact on both spasticity and the potential for improving range of movement. So we're now going to think about activity as opposed to body structure and function, and look at the impact on function. So this was looking at comparing botulinum toxin versus usual care or physiotherapy, and the outcome was longer-term function at the longer-term follow-up. So what you will see here is only one of the studies showed that there was statistical significance favouring botulinum toxin, and if all the other studies all had a much wider confidence interval, so that probably indicates that it was better for some people, but it wasn't better for everybody. And the summary of the results, that diamond shape, is actually straddling the line. So again, that's showing us it's not better for everybody. Some people did well, some people didn't. So that tells us that from the research studies, we don't clearly see an improvement in function in everybody. So better for spasticity and range of movement, but not necessarily better for function. Right, we're going to look at an adult study now, because this is just I want to make a bit of a point about this. So there's a table here of the impact on active function of the arm. So we've looked at the leg in paediatrics, we're going to look at the arm in adults. So this was a study by Helen Rogers' team up in Newcastle, the Botulinum study. So it's a little bit old now, but what they basically looked at was whether botulinum toxin improved activity of the arm. So their outcome measures were the Action Research Arm Test and the 9-hole peg test. And you'll see, so that you've got the results of what the control did and what the intervention did, and you'll see from my arrow there was a difference in active function at 3 months between the control group and the botulinum toxin group, but this wasn't upheld at 12 months, and there was no statistical difference in the 9-hole peg test. So that seems to indicate the impact on active function of the arm is a bit unclear. The next slide shows the impact on passive function of the arm. So passive function, so active function is basically using the arm to do things yourself. Passive function is how we look after an arm that doesn't really function very well. So for example, how easy is it to put your arm through a sleeve? How easy is it to cut your nails or wash your hand, and so on. So this shows more benefits. So there were some statistical improvements, both in the ease of dressing and opening the hand and cutting the nails. So in the Botulinum study, it appeared that botulinum toxin had a better effect on passive care of the arm than on active care of the arm. Now, the Botulinum study was quite a large study, and the criteria for people to be eligible to enter the study were that they had to have a modified Ashworth scale of 2 or more. And when Helen came down to Exeter a while ago to present the results of the study, we had the chance to have a conversation afterwards. And because with every research study, you put in, you get it all up and running, and then you're all, gosh, we've got to get people recruited, we've got to get people recruited. And I said to Helen, did you put people in the study who had spasticity, but that you probably wouldn't have treated in a spasticity clinic with the goal setting and so on? And she said, well, yes, we did. So probably what the Botul study shows, going on to the next slide now, is that routinely treating everybody with spasticity with botulinum toxin probably isn't going to be that helpful, particularly for active function. So there's probably something about the fact we need to be a bit more discerning. So we know it's good for spasticity, we know it's good for movement, although we have to put a caveat around that. It won't affect contracture if there's fixed contracture. But the impact on function is less clear. So botulinum toxin on its own won't improve active use of a limb. You'll need to think about that in terms of how does that fit with all the other things that impact on activity, strength, motor control, coordination, sensation, and so on. So for me, it's all about getting the right patient and the right goal setting. And there are some studies going on now, particularly the ULIS studies, which are all about evaluating the use of botulinum toxin in the real world. So international studies that look at many centres and then look at the goals and look at how it's used. Because in some ways what we risk with trying to go for big randomised controlled trials is we just push people into the study because they're eligible, because they've got the right amount of spasticity, when in fact, as clinicians, we all know that we want to be much more discerning about whether this is the right treatment for that person. Right, so I think I've got a list now of risks and adverse events, so just to round off all the practical stuff. So, because of the way botulinum toxin works, there are a few risks that we might expect. So, for example, it potentially causes weakness. So, you might have a patient where you think causing weakness won't be a problem. So, for example, if you have a patient with spasticity who has a very clenched fist, it's really hard to open. You might think, well, it doesn't matter if I'm actually going to make their finger flexors weaker, because actually that will enable us to wash their hand. Whereas if you've got somebody and you are thinking they've got some spasticity or some dystonia that makes using the hand difficult, you need to bear in mind the fact that you might be making them weaker too. Botulinum toxin can also cause dysphagia. So that's mostly common when the muscles being injected are closer to the neck. So either in the neck themselves or possibly sort of shoulder girdle area. So then dysphagia, there's a bit of spread of the toxin, so people may then experience swallowing problems. Flu-like symptoms is also a very common side effect. It affects about 1 in 100 people, so that's something we counsel people about. Rarer side effects, but possibly more significant ones, include anaphylaxis. So it's estimated the risk of anaphylaxis is 1 in 10,000, but obviously it can be quite severe. There's been 1 death reported after somebody had an injection of botulinum toxin mixed with lidocaine. So obviously you don't know which is the culprit drug or whether you've just invented a new drug by mixing them together. But obviously you need to think that if there's that kind of risk, is this the right thing to do? The role of acetylcholine is also can be implicated in seizures. So people with botulinum toxin can have seizures afterwards, particularly if they've got a form of epilepsy. It can also affect arrhythmias. So if you've got a stroke patient who perhaps had their stroke because of AF, you might want to bear that in mind. And then other adverse events that are more procedural, rather than to do with botulinum toxin, are about your injection technique. So if you're aiming for pectoralis major, it might be possible to give it is possible to give somebody a pneumothorax if your injection goes a bit deep. And I did meet an injector once, a medic who told me he gave somebody a pneumothorax, giving them a botulinum toxin injection, so it does happen. It's also possible, obviously, to cause nerve or vessel damage. Your nerves heading towards muscles tend to be quite close to large vessels as well. So people have to be really clear on their anatomy to make sure they don't inadvertently damage anything else. Okay, so we're going to move on now to thinking about how we practice in spasticity management and how botulinum toxin works in that. So there's a diagram here from the Royal College of Physicians guidelines on spasticity management with botulinum toxin. So this just gives us an overall flow chart, and I'm going to press my button so it, sorry that sounds a bit odd, doesn't it? For me, the first thing about spasticity management is it's all about education, education, education. And obviously if we see somebody with spasticity right at the start, it's all about are we convinced there aren't any other factors going on that are provoking their spasticity and making things worse. So things like urinary tract infections, constipation, pressure ulcers or skin damage can all make spasticity worse. There was a recent study with people with multiple sclerosis asking them what they felt made their spasticity worse. That included stress, temperature outside, and so on. So our first thing we'd always do in spasticity management is let's make sure there's no provoking factors, and let's really educate people about how to manage their spasticity themselves. We're going to go back to the picture now of the ICF.
Which one's that?
So it's the one titled Assessment. So does it come up, Andy, with the little bits under the body function, activity and participation of what you right? So what I've tried to think about here is if we're assessing somebody with spasticity, and forgive me if you're very familiar with this. So from a body function and structure point of view, there are a number of things we would want to formally assess. So spasticity, I'm thinking about what measure you'd use of that, whether you'd use the Ashworth or the Tardio. I don't want to get into an argument about that. I've done it too much in my life. I just think just use whatever you feel is appropriate. Want to measure range of movement, strength, motor control. Want to know if pain was a factor, and anything else that you felt fitted in with that kind of impairment level. In terms of activity, we'd want to look at active use and passive use. So I don't think I really thought about passive use until I got into working in spasticity management, and we see quite a lot of that, so that's become increasingly important to me. And then under participation, we'd obviously want to think about what's the impact of that person's spasticity on their quality of life. And that might just be what people say. I was at a presentation last week about spasticity management where somebody shared a case history of a lady they'd seen who, so it was a doctor, a Canadian doctor, and he was very clear that he thought she had this problem. So she came in, she had a non-functional arm, and he said, well, her arm clearly needed treatment. And she was quite a feisty lady, and she said to him, actually that's not my main problem. So my main problem is my toe. So she had a toe that her big toe was extended, what we tend to call hitchhiker's toe. And she basically said, that's my problem, because I can't go to the opera, because I can't put on my opera shoes. And he then presented it as he still injected her arm because he thought it was right, but he treated her toe as well. And he presented it as an example of actually really the importance of actually listening to what's important and what affects quality of life. Right, we have a slide about goal setting and how we really think about what matters to me, and this is it as rehabilitationists. So I've got a couple of examples from clinic. So one of the people I see in clinic said, we talked about what do you want to get out of an injection. And what he said was it actually takes me 2 to 3 hours to fall asleep when I go to bed because my arm jumps quite a lot. I want to be able to go to sleep quicker. So that was quite easy to craft that into a goal. Now I don't know how long it's going to take me to fall asleep after botulinum toxin, but we agreed that aiming for an hour, to fall asleep in an hour was reasonable. Because A, if it was going to take a lot longer than that, he might not want to be bothered to do it. And B, it might take him a while to settle down. And then I had another lady who came into clinic who just said, I want to be able to play golf again. Now this lady had a non-functional arm, so potential for real mismatch there between what person wants to achieve and what I as a clinician think I'm going to be able to deliver. Because if you're several years post-stroke, you have a non-functional arm, I'm unlikely to be able to help you play golf again with both arms. So, and that's the conversation we need to have, is what is realistic. Because there is some evidence that after botulinum toxin, people can disengage from treatment because there's been that mismatch between what the person's expectations are and what the botulinum toxin is really going to be able to deliver. Okay, we're going to go back to the Royal College of Physicians diagram. I do work hard just to keep changing the slides. So we've talked about the importance of education. We talked about assessment and then starting to develop a multidisciplinary strategy for how you're going to help with the patient. If you then look to the right side of the flowchart, it talks about what the options are for focal intervention. So we talked earlier about the fact that botulinum toxin needs to be delivered into each individual muscle. So that makes it a very focal treatment. So if you've got widespread spasticity, it's not going to be tolerable to inject every single muscle, and equally we wouldn't be able to give you appropriate dose. It would be poisonous. So it's a focal treatment. So focal treatments tend to include both botulinum toxin, but also all our physiotherapy type techniques, casting, splinting, task practice, positioning, all of that stuff. And my little blue line down the side is really just a bit of a nudge to think about those things in combination. So don't think I need to do physiotherapy for a few months, and then if it's not working, I need to refer them for a botulinum toxin injection. If you've got a patient who's really acute and you think their spasticity is going to change very, very rapidly, don't waste loads and loads of time on one thing alone if you think it's not working. Try and get them in combination really quickly, because then it just makes it's going to make it much more effective. So yes, I'm quite pro early treatment if things aren't working, and I get very get disappointed when people come to clinic who've been having therapy for a long time, and then it's like, oh, now come and fix it. Like, well, actually, we should have all got together right at the beginning. So that's what I said about that. Right, I've got an example now. So this is a picture of a lady that came to clinic. So what she said was, I want to have less pain in my arm. So she's got a left hemiplegia and quite a tight arm, and I want to be able to put my wedding ring back on. So again, that's what matters to me, isn't it? That was really important to her, wearing a wedding ring, because she who's lost it. And there's a picture of us actually trying to passively open her hand, and you can see her hand opens a fair way. So what we did after that was actually try to drill down into how do we measure the amount of pain she's in, what's the amount, what's the duration, and then we need to think about, well, what intervention would support that goal. So both from a multi-professional point of view and a botulinum toxin. So she's obviously got a hand that's quite tight. And looking at how she came into clinic, she obviously spends most of the day with her hand in that position. So a big part of her treatment is going to involve some kind of splinting or positioning device to stretch her hand out. Because obviously passively you can get it into a better posture. And obviously then to make it, that could be combined with botulinum toxin to make that positioning easier still. Make it easier for her to put her wedding ring on and get it off if she needs to with her finger. Are we doing all right, Andy? Right, so we've got a bit of guidance now on referring people for botulinum toxin and providing aftercare. That's the next slide. So this is just thinking about if you're going to do a treatment or if you're going to refer somebody to your local clinic. So you've probably understood that for me it's really important to understand what is the patient and carer expectation. If you're referring to a medical run botulinum toxin clinic, they may have quite short sessions as well. So although the guidelines that everybody works to, whether they're a doctor injecting or a physio injecting or a nurse injecting, are the same, we know that clinics are widely different. So if you're thinking of sending somebody, it's worth putting the time in yourself about really understanding not just what you're hoping to get out of referring them for treatment, but also what the patient and carer really want to get out of that, and then being able to communicate that to the clinic that they're going to. You need to think about what the assessment shows. So how much of this problem is spasticity and how much is contracture. And it's not always easy to be black and white. So before I did my injection course, I thought, of course you can tell the difference, but I don't think you can anymore. Sometimes it's blindingly obvious. Sometimes, you know, there's a mixture of both, and you've got somebody who's quite contracted, but botulinum toxin will enable there to be a small amount of movement away from some of the contracture. So, but it's helpful, because if you've got somebody with a completely fixed contracture, say for an example an ankle that's in really severe equinus deformity, and you're thinking you want to refer somebody for a botulinum toxin to get the person to be able to stand, that's probably really unlikely to happen. It would be much better to think about, actually, should we think about a surgical option near the beginning. So yes, and what is the goal? So what is the overall goal? What are we aiming for? Now, if you're then picking up a person who's been injected and is coming back to you, you would want to know what is the product used and what was the dose. And as we said at the beginning, 3 types of botulinum toxin, A, 1 and B. So you want to know which one's been used, because they're not comparable. So if someone says botulinum toxin 100 units, that means nothing, because you'd need to know which product they have. And I think it's helpful to know that, because if you feel the injection isn't helpful, that might then help us make a bit of a decision about what we do next. You'll want to think about the timing of follow-up. So the recommendation is that if somebody's had a botulinum toxin injection, they're then reviewed within the next week to 2 weeks to then develop the multidisciplinary plan. So if we have someone that comes to our clinic who's going to need a splint or an orthotic afterwards, we tend to sometimes delay the treatment until we know that they're going to have that appointment 2 weeks, which is when the botulinum toxin will have had the peak effect. You then need to think about a review at 4 to 6 weeks to look at, has the goal been achieved and have there been any adverse events. So that's your point to really consider, has the whole package worked or not. You'll obviously want to think about what's the optimum aftercare to give people. We need to think really seriously about what the patient and carer are doing to support the whole thing, because it's not a passive activity. We don't just give you a botulinum toxin to make you better, and in fact rehabilitation is a 24-hour activity, isn't it? So if you're a physiotherapist or a therapist following someone up after botulinum toxin, what you do is only going to be a tiny part of their whole day and whole life. So there needs to be clear agreement about what they are going to practice. How are they going to support the impact of the botulinum toxin? I spoke to somebody once in paediatrics about paediatric treatment of botulinum toxin, and she said this was her view, she felt it was often really difficult for families to continue to provide ongoing care, enabling care, and follow-up physical management plans for children. And she felt quite a lot of that coalesced around botulinum toxin injections, because then everyone was super motivated, and it was almost a bit of a kickstart to getting everything else done. But everything else needs to be done really all the time. And then you also need to think as well about how you're going to measure your outcome of your therapy and botulinum toxin combined. So we're going to talk a bit about outcome measures in a moment. Right now, outcome measures. So I've got some examples. So many of these are in the guidelines that we're going to talk about at the end. So obviously goal attainment is a key one. So I used to not be very keen on goal attainment scaling, the initial version. seemed to make a bit of an ology for me of trying to do all the calculations. So I quite like the gaslight, where both the clinician and the patient can rate how they think the goal, how things went. And obviously, if you're looking at very bespoke goals, so for example, I want to go to sleep in an hour, you're not going to find another outcome measure that measures that. So you're going to have to say, this is the goal, go to sleep in an hour, and say, did we achieve that or didn't we? Did we get part of the way there? So goal attainment's good. And then we've got some outcome measures related to body structure and function. So the Ashworth scale, the modified Ashworth, the Tardieu, range of movement, there's spasm frequency, so there's the PEN scale of how frequently you have a spasm, if that's a particular problem. There's also an associated reaction rating scale that was developed at Northwick Park. So if that's the key issue, you can scale that. And then there's measures of activities and more functional measures. So both ARM-A and Leg-A are produced by King's, by Stephen Ashford. So they are scales that combine active and passive function of both the arm and of the leg. So they are highly recommended for spasticity management. Or you could choose other ones of mobility, such as gait speed, if you're trying to improve gait. Okay, so the next slide is really it's trying to bring it all together. So the picture in the top right-hand corner is of this lady when she came to clinic the first time. So she actually had a bit of dystonia and had a posture of her index finger was in the neutral posture, but all her other fingers were flexed. So talking to she was undergoing investigations of why she developed this dystonia at this point in her life, so she didn't have a clear diagnosis. So when we talked to her about what she was expecting when she came to clinic, and I tend to say to people, when you knew you were coming here today, what were you hoping to get out of the appointment? And she said, well, I want you to give me my hand back, I want to have a normal hand. So that's, so we have to have a conversation, don't we, about what we think is going to be possible. So she had this dystonic hand. She had very little active movement in her hand, but it was possible to passively move her fingers. So we had a conversation about what we thought botulinum toxin could achieve. It could probably make her fingers a bit looser, but that we weren't really sure it would really improve the activity of her hand. And so we spent a bit of time discussing that, and then we agreed what the goals were going to be, so that she wanted to be able to open her hand to cut her own nails. She wanted the hand to look normal, so she didn't want this hand that was in this kind of posture. She wanted to look normal if she was out. She also wanted to do the washing up. We had a bit of discussion about, well, actually, so that could involve, if you know, could involve stabilising objects with a hand if it's in a better posture. I never say to people, your arm will never work again, because I don't know that for sure. I try to be clear though, because when I started injecting, I did used to think, oh, if someone's got quite a lot of spasticity or dystonia in their hand, perhaps if I inject botulinum toxin, it will unmask some activity that's hidden, and it never really has. So I don't. If people say they want their hand to work better, I very much say I don't feel confident that that will happen. And I try to state it in a way that is reasonable, but doesn't leave room for doubt, that people then say, well, I thought it would make my arm better. Because that's, if people come back for follow-up and say, well, my arm still doesn't work, that's not really helped anybody. So these were the goals. So what was the product used? So in the clinic I work at, we use Botox. And the recommendation is, it doesn't matter which product you use, but you should probably stick to the same one. Because they're all different and they've got all different dosing and they're not comparable, you shouldn't be setting up a clinic where you've got 3 products and you might just work with whatever they've sent up from pharmacy on the day. So we use Botox for this lady, and you'll see from the posture of her hand that she's quite flexed at the proximal interphalangeal joint. So in view of that, we injected Flex digitorum superficialis. and she had 10 units of Botox injected into each slip of the second to fourth part. So you get the idea, don't you, about how good you have to be with your anatomy. And we also, because her fingers were quite adducted, so quite close together, we injected the interossei of her hand, because they tend to be what adduct the fingers. So she had a tiny amount into each one. So what was the optimum aftercare to go with that? Well, we weren't really looking for an improvement in activity, but you obviously wouldn't stop people from trying to do some active movement if they can tap into it. But the main issue for her was lots of stretching, lots of positioning of the hand, that 24-hour postural management approach, so considering a splint to keep the fingers in a good position. In terms of outcome measures, we used the RMA, but we also rated her satisfaction with the appearance of her arm, because that was quite important to her. And she agreed to help with the stretching and positioning. And the picture in the right at the bottom is her hand when she came back at the 4 to 6 week mark. So she felt that she could sit outside at a cafe in a restaurant with her hand, and it looked much more normal than it had at the beginning. So she was very satisfied with that. And it was easier to look after her hand. So I'd be lying if I said she didn't still want a hand that she could actively move. But we agreed that that was a reasonable outcome. And then we looked at her again to see whether we were going to repeat that. Right, so we'll talk a little bit about whether you want to be an injector if you're not already one. So this is all about really improving access to care, isn't it? But we don't need millions of injectors, because there's not that many people. But if you're struggling to access a clinic, because they're very busy, it might be worth thinking about whether that's appropriate to provide that service more locally. So being an injector probably has two aspects. So one aspect is administering the injection. So that's a highly skilled activity. And if you're thinking of doing that, you're going to need to brush up on your anatomy, because you're going to need to identify where the slips of flexor digitorum superficialis, flexor digitorum profundus, where they all are. And if you think it's hard to find them in your arm normally and think about where they are, wait till you've got a person that's got quite a spastic arm and you're trying to work out where they are then to do an injection. And you really have to hone your decision making, because it's one thing sending somebody to a clinic and saying inject them with botulinum toxin. When you're actually doing it, you feel the weight of the decision much more. You'll need to think about training and mentorship. So the CSP produced an information paper about standards for injectors, and that talks about the fact there are different routes to being an injector. So you can either do a formal academic course, and there have been a number of courses running in the UK at master's level, so typically short courses at master's level that enable you to be an injector. But equally, there are routes where you can do some mentorship within your organisation. So as long as that meets the same standards, and for both routes, you will need to do some mentored practice within the organisation you work. So you'll need a mentor to observe you doing some injections as you go along. If you're administering the injection, you also need to think about what your route is to get a supply of the drug. So is someone going to prescribe the drug for you, which is a patient-specific direction, that's a normal prescription, or are you going to use a patient group direction, which is the legal framework whereby non-prescribers can provide medicines to people. There's been a bit of a shift away from using patient group directions for planned treatment. NICE produced some guidance quite a while ago saying they didn't feel that was particularly appropriate. So that might be something you need to think about. The other part of potentially being an injector is actually being a prescriber, so you can then act to prescribe the medicine as well as administer it. And that's obviously the non-medical prescribing course, which is open to physiotherapists, among others. Okay, and just to wrap it up, there's a slide of some resources. So the Royal College of Physicians produced the Spasticity in Adults use of botulinum toxin guidelines in 2018. So that was produced by a multidisciplinary group, doctors, physiotherapists and occupational therapists, and with some service user input. So that's a great resource. That's on the RCP website, and you can access that electronically and download it. It's got a summary of all the resources, so that's very helpful. I'm also aware that many of the pharmaceutical companies produce different resources to support botulinum toxin use and decision making. So I've listed a couple here that I'm familiar with through my links with Allergan, who are the manufacturer of Botox. So they've produced two things that are coming out later this year. One is a guide called Spot the Signs, which is about early identification of spasticity. So actually looking at stroke patients early on and working out who is at most at risk of developing spasticity, so you can plan to manage that. And they have also produced an MDT toolkit to support practice. So that's an international piece of work. I don't think it'll say very much different from what's in the RCP guidelines. So, but it might be helpful to look out for if you see it. I think that's the end of my slides. Thanks, girls. Right. That was helpful.
Big thank you to Rhoda. We can start some questions, and the first one that I've got here is what is the optimum time to start treatment with botulinum toxin?
I would say that I would say don't wait too long. So if you've got someone who's got a very acute, so if you're, for example, in a neurosurgical unit and you've got somebody with high tone, it might be very different tomorrow, mightn't it? So you might want to wait a day or two and see what the trajectory of change is. And you might want to see how you get on with your physical measures, and you obviously need to consider what the risks are of botulinum toxin. But if all that's been equal and you feel you're not seeing a rapid improvement with physical measures alone, I wouldn't delay waiting. And Peter Harding told me a scary story a few years ago where he said he does a lot of legal work. I'm not sure why I'm saying this actually. And he'd seen, I think they'd been asked to provide some evidence about a lady who developed quite severe contracture after a brain injury, and you know, there was a perceived failure in terms of MDT practice to really address that. So if you're feeling you're not winning, either acutely or chronically, you think actually I really don't, I'm not sure, refer people in. Because it's better to see people and actually make a decision, actually no, there isn't anything we can do to help this person, than it is to then have somebody later on with a contracture that could have been prevented.
Okay, next question is how can we assess if treatment could improve active movement?
Okay, so I think I said, if somebody's got really what appears to be a non-functional arm, when I started injecting, there were a few people where I thought, oh, perhaps there is some movement underneath that spasticity, and by treating with botulinum toxin, I'll unmask it. And I probably treated 2-3 people that way, and I didn't really see much benefit. I'm going to look at Laura now and ask if she's... No, so Laura says the same. So I think if it's probably a non-functional arm, I wouldn't give any expectation that there's going to be any improvement in active function. Not to say to people, you know, people go on hoping, don't they? But I would say botulinum toxin won't help that. So you can continue working on your arm and hope that your arm gets better, whatever, but don't have a botulinum toxin injection for that. We will give you a botulinum toxin injection to make your hand easier to look after. So that brings us back to the people that have got some activity, but perhaps that activity is hampered by spasticity or dystonia. So that's very individual. You'll need to make a decision, what is the activity, what is the impact of spasticity, what would the goal be, and being really specific. So for example, we had somebody whose goal was to be able to use her hairdryer in her affected arm, in her affected hand, and it was really hard to work out how to analyse that movement, to actually work out if botulinum toxin would help, and if we were going to do botulinum toxin, what muscles we'd inject. She had quite a dystonic hand. So in the end, she brought her hairdryer in, and we all had a bit of a go, another look at it, and got a few heads around to say, well, what should we do? So think about what is, just really take time to look at it, and then make a decision. But if there's some activity, and it appears that spasticity is making that worse, that's probably the thing that is likely to help. Do bear in mind, though, that the weakening can be an issue then. I had a gentleman I treated once, and he said to me afterwards, I can't do up my laces anymore. And we'd had this conversation about the fact it might be weaker, but he hadn't heard that, and we'd made something easier in terms of being able to open his hand for something, but he couldn't really clench it together to tie his shoelaces. So just need to bear all of that in mind.
Okay, so we've got some other questions. From Lily Jenkins, is there a regional support network dedicated to people doing this kind of practice? Or national network, in fact?
So Lily, I don't know if you mean for people who are injectors, or for people who are providing spasticity management. So there have been various discussions over the years about whether there should be an organised group for botulinum toxin injection, and I think the feeling is the numbers are still relatively small. So there isn't an organised group, and I guess if you feel there should be, it might be something we need to discuss with ACPIN, and I don't know, maybe that's worth thinking about now as the numbers of injectors grow. There's usually a fair bit of money put into education, particularly by the pharmaceutical companies, because they want to support people who are working in this way. So I know that many of the pharmaceutical companies organise networks and meetings. So, for example, Allergan typically tend to organise an annual meeting every year about bringing together people who are either injectors or are thinking of becoming injectors. This year that's going to be online and actually delivered as a series of evening sessions, webinars in November. So there are some, and the good thing about those meetings was that you could actually network with a lot of other people. I guess that's something maybe to discuss with ACPIN, whether there could be a breakout group. I don't know. I'll leave that with Andy.
Okay, and Mike Hones is asking if there's anything specific to say about adding in use of trophic stimulators, electrical muscle stimulation at the same time.
Oh, okay, that's an interesting question. So I think Italy, is it Italy? There's a very strongly held view in Italy that using electrical stimulation helps the injection. So the argument is, when you put the injection in, the injection the botulinum toxin almost gets drawn to increased activity. So I think there is a consultant in Italy who does a lot of work stimulating the muscle electrically immediately after the injection. Now there are also many other people that think, well, if it's a spastic muscle, it's quite active anyway, so don't believe that adds anything. But there hasn't ever really been a big proper study to compare does it make a difference or not? In terms of aftercare, it's one of your tools in your toolbox, isn't it? So looking at the evidence for electrical activity of muscles in rehabilitation would be the same as for whether there's an injection or not.
Okay, here's one from our very own Penny Weeks. Resources, she's asking about resources for younger children. Is there anything specific available about explaining what you're hoping or thinking of doing so that they understand the treatment better, that they may be agreeing to?
That's a really good question. So I don't work with children. I don't know, Penny. I think my understanding was that most of our children so in South Devon, most of our children probably go to Bristol for their botulinum toxin treatment. And it's been a while since I spoke to the team at Bristol, but when we last spoke to them, they anaesthetised most of the children to have botulinum toxin injection. Because I remember at one point we had a bit of a conversation with them about the fact that when they transition, they then rock up to our clinic and just get given the injection, which can obviously be a bit of a shock if you're used to having an anaesthetic. And I think Bristol, and may well have already done so, were then looking at how they prepared people for a transition and recognised that as children got older. I don't know what resources are used for goal setting and preparation for the injection. I don't know.
Okay, so here's the last question, I think, from Liz Meakin. Can you comment on the efficacy of the use of Botox, botulinum toxin? There are other brands available. On the efficacy where other wounds, particularly pressure wounds, or perhaps I think Liz is talking about the sores that may be present in a hand where there's been a lot of contracture, etc., where it goes all gummy and yeah, we've all seen those, I'm sure.
So,
does it reduce the effect?
So Liz, I think you're meaning. So I hope that's what you're meaning, Liz. So if you've got a hand, we've treated quite a few people with hands where they have a hand that's fairly smelly. So treatment, what we usually do would be to swab the hand while we're examining it. If we then decide to inject, if we've got a hand like that and it's very difficult to open the hand, if we can only open it a tiny way and then it's contracted, opening that tiny way will hopefully then enable a hand with a sore in it to heal. And often the actual injection we would do will be actually up here. So your long finger flexors are up here. So they're actually nowhere near the hand. And if you wanted to do the interossei of the hand, you'd go through the back of the hand to do them. So you won't. So I'm not quite sure if I've understood it correctly. The injection will be nowhere near the actual wound itself, but I have certainly used injections to help enable people who have a very stiff, smelly hand. And if we didn't think botulinum toxin would help, I would still welcome seeing that kind of thing in our clinic, because I worry, particularly with people that live in care homes, that there's sometimes a bit of a perception, or we can't do anything about that. And sometimes it's difficult, but we need to just try. And we did some work with our tissue viability team about actually what kind of dressings might we use if people have very stiff hands, or we have nails that are digging in, and so on. Is there anything else you'd say to that, Laura?
Yeah, I mean, I think it's not just for palm, is it, that we've had hand on chest.
Yeah, so Laura was saying about people having a sore from their arm being on their chest. knees together, making it difficult to wash in between your legs. That can help with all of that. I did have somebody who had a really terrible stiff hand and nails that hadn't been cut, that were really, really long, and then were sort of curling out again. And it was really hard to examine, so I wasn't convinced it wasn't all just fixed contracture. And our hand surgeon had also been asked to see this person, and he wasn't greatly keen on surgery. So in the end, we actually saw the person all together. It was a really good experience. So we had the hand surgeon, we actually had an anaesthetist who gave the person a nerve block so that we could examine them properly. And we had the tissue viability team that came, and also the podiatrist came to help with all the nails. And it was a really positive experience for me, because the anaesthetist was able to give a nerve block, which then took away the fact that this hand, which was so horrible and painful, we could actually examine it properly. So the hand surgeon then opened the hand, and it was quite tight. It was almost a bit of a manipulation, really, but managed to get the hand quite open. And the next day it was quite tight, at which point I was then happy to do a botulinum and toxin injection, because I'd seen how it could work. And by then we'd had a bit of a reset, because we'd managed to cut the gentleman's nails, get a soft splint sorted out, and so on. So yeah, I think if you see somebody with a horrible smelly hand, that's right up our alley, really.
I think the key thing is that anybody who's going to be doing the injection is a very experienced person. You can refer to that person any time, and then they're going to make lots of components to that assessment as to when to actually use the injection. So somebody with that sort of presentation is likely to have been in that condition for some time, aren't they? And then, so you don't have to inject the moment you see them. You can say, well, let's wait for that wound to heal, let's do this in between, and bring them back at a slightly later time.
Yeah, although to be honest, the referrals that we get that say somebody's got a wound in their hand, they tend to be the referrals we treat quite urgently, because they're often very painful. It's a source of infection. So often I see it more that we'll do an injection to make the fingers move away from the palm, so that it's then possible to heal the wound, because often the wound is there in those really difficult hands, because the fingernails keep digging in, and then that's painful. So then tone goes up, and it all just becomes a vicious circle. So those referrals tend to be a bit of a red light, really, don't they? We tend to prioritise those.
Good. Everybody's saying thank you, thank you, thank you. There are lots and lots and lots of those, so it just remains to say thank you very much to Rhoda, and thank you very much to the venue here at Hydro Hub at Sealhane, and our amazing audience, Laura, who's done a sterling job in giving minimal encourages and nods of the head to Laura. Thanks very much. That's all we've got time for.
Stay safe.
Good night to all.